Budget Office, amongst a number of hats that he has worn and is wearing. Thank you, and thanks for being with us this morning.
Well, thank you very much. Thank you everyone for coming. I want to applaud the efforts of Dr. Burgess and the Health Caucus to understand these issues better. And I owe a personal debt to the Manhattan Institute, which is currently hosting me as a fellow in their Center for American Progress, or for Medical Progress, and where I've written some sketches of reforms that I think would be good ways for America to go. And I hope by now in this debate there's no longer any confusion about the need for reform. We have in America a healthcare system which spends too much money, which delivers too little in quality results for the dollars that we spend, leaves too many Americans uninsured, and leaves far too many in fear of losing their insurance. And so the question is, what is the best path forward from this situation, which we find so unacceptable? And on the issue of pre-existing conditions, one approach is to solve the problem after the fact, which is to essentially say, what are we going to do with these people who have pre-existing conditions? And you've seen approaches which are market reforms of the type that Karen just discussed. There are alternatives as well. One which I have argued for is, as part of a broader state-based approach to healthcare reform, is to have states provide open enrollment periods, say from November of this year through March of next year, during which all individuals would be eligible to go in and get a one-time ability to receive coverage, essentially a short window for guaranteed issue. And after that enrollment period, those who chose not to take advantage of it would be subject to a late enrollment penalty. What would that do? Well, it would give those who currently find it impossible to get sensible coverage in the individual market a chance to get in despite their medical conditions. And because of the enrollment period, it would give those individuals who are young, healthy, an incentive to get in during the period when they are young and healthy, so as not to have to pay the enrollment period later, and thus balance the pools that insurers must face in the reform, instead of giving them strictly a pool which is more expensive and costly and sicker than the pool on average. So there are reforms short of draconian mandates from the federal government which would give incentives to get people into coverage and which would allow private insurers to continue to do their business. I believe that this would be a sensible approach to a state-based reform, and you could pair this with targets for states to meet on a path toward universal coverage, and allow them to deploy whatever state-based resources they thought were most appropriate. We've seen Massachusetts undertake a reform that included mandates, not my favorite reforms, but certainly their approach. We could see if it works. Utah, a very red state, has done bipartisan reform with exchanges and the like, and we can see how it works. We could take advantage of the fact that not only is there a great diversity of differences in insurance coverage across the 50 states, where the demography is very different, the rates of uninsurance are very different, the rates of Medicaid take-up are very different, but also those legislatures most in tune with the desires and needs of the populations could undertake reforms that led us to a path to greater coverage, and we could embed in that these kinds of reforms. The second approach, and the one that I think we really ought to be looking toward achieving, is to solve the problem of pre-existing conditions by having pre-existing coverage, which is to say, have people in insurance products which are portable and renewable, and as a result will go with them regardless of their health condition or their employment condition. So again, as a transitional approach, one might imagine pairing an open enrollment period with modifications to the individual market that had something that looked like the HIPAA protections in the employer market. If you stay covered and keep your premiums paid, your policy gets renewed. And as a result, we would have individuals, in particular young individuals, getting into policies which they would then carry through their lives, and those policies would be renewable. They would go with them from job to job, solving a portability problem which at one point was the centerpiece of this debate, but which seems to have been lost over the course of the past 6 months. It would go with those individuals from job to home as they had their children and changed their lifestyles. It would go with them from job to retirement and solve the problem of how do we get to Medicare eligibility when we want to retire at something like 62. So if we move toward more portable insurance policies and we have more individuals in those, we would get a product that better fit the lifestyles of Americans and solves many problems. The portability should be solved, but also the fear of losing your insurance. You would have an insurance policy, and that is high on many Americans' greatest fear in the insurance market, not what they might be able to get, but what they're more likely to lose. This also, I think, would lead us down the path toward the kinds of reforms that we genuinely need. Initially, the promise of healthcare reform was to lower the cost of care, of the delivery and use of medical services in the United States, especially for those with pre-existing conditions. Many of whom have a chronic disease that are responsible for the vast majority of costs in the U.S. system. We have seen, according to my old outfit, the CBO, bills come out of the House that do not bend the cost curve and do not fundamentally address this, which is the core problem in the American system. The entitlement that's set up in the House program grows at 8% a year as far as the eye can see, faster than this economy will grow, faster than tax revenues will grow, and thus is a fiscal risk in addition to not being a step forward in healthcare reform. Oddly enough, the Senate bill that was delivered by the Senate Finance Committee also has an entitlement that grows at 8% per year. People talk less about that, but to my eye, it also must not bend the cost curve and thus fail the fundamental test of lowering the growth rate of healthcare costs, which ultimately must be covered by insurance products. And if we could move toward insurance products that went with people on a lifetime basis, we would build a business model for America's insurers to care about the life cycle costs of treatments. If there were interventions, prevention, which we hear so much about, early detection of diseases that would pay off over a life cycle as opposed to simply a year during which someone might hold a product for a year at a time, they would undertake that as a very sensible business product. And we would move insurers toward what everyone would like, which is keeping people healthy, doing things in the lowest cost fashion, they have every incentive to do that, and generating a healthcare system that rewards quality and promotes portability of products. So I believe that a better approach to insurance reform is part and parcel of a real healthcare reform that would generate the kinds of savings that we need in the United States if we were to go down that path. Deliver real reforms that lower the cost of healthcare. We could also provide the subsidies necessary to help low-income Americans get these products and hold them without threatening the fiscal future of the federal government or America's families. And that strikes me as a much better way for this country to go than some of the approaches that are currently on the table. And it is certainly not too late to stop, rethink this, and move that way, especially in a bipartisan fashion. Thank you.
Thank you, Doug. And then our final panelist this morning is